you. Yeah. Salam sejahtera. Good morning to everyone here, ladies and gentlemen. See a gentleman here. I also see that team here. Welcome. I also must address our virtual audience here that we are going on live today on NCSM Facebook and also Pink Unity Facebook. Welcome. Welcome to this talk. We have invited a very special guest speaker, Dr. Suraya Baharudin. My name is Amy Noor Fariza. On behalf of Pink Unity, once again, and NCSM, welcome to our Resource Wellness Center. I will give you a very short brief on our speaker, where we are going to talk about some very interesting updates on breast cancer and management. A very short one, because we are running out of time. Dr. Suraya, as we all know, she was a general surgeon at Hospital Raja Perempuan Sana Kota Baru. That's in 2009 to 2010. It used to be one of the biggest, I hope it is still the biggest hospital in Kota Baru, and a very prestigious one back in the British era. The very interesting part of this hospital is part of a national network with Ministry of Health establishing a clinical research center where they are responsible for conducting quality and ethical research to improve patient outcome. That's really one of the very interesting involvement that they are. And very soon, Dr. Suraya is posted to Hospital Ampang in Kuala Lumpur, a 2-year stint there, and she moved on to Hospital Sultana Nur Zahira for another 2 years before she was posted to Hospital Putrajaya Institute Cancer Negara. 2 years being there, she in between that training, and all the practice at this hotel, Dr. Suraya also took up some training in breast oncoloplasty and reconstructive at Sri Raj Hospital in Bangkok, and endoscopic breast surgery in Japan. That's with the Nippon Medical Hospital. That's in Tokyo itself. She continued her career as consultant general, breast and endocrine surgeon back to Hospital Putrajaya in 2015 to 2016. Soon after, she joined as a consultant general, breast and endocrine surgeon with Hospital Selayang, where they need to have a lot of exposure from different areas and the different government hospitals. That's for another 2 years. Dr. Suraya has a medical journal publication in her own field of expertise. I'm sure you could also, if you'd like to know more, you could Google more information from the website. Would you like to know furthermore, if I may, about Dr. Suraya? She's trained in the Bachelor of Medicine and Surgery in Pakistan, as well as Master in Surgery with Hospital UKM, Fellowship in Breast and Endocrine Surgery, Certificate in Oncoplasty and Breast Reconstruction Surgery, as I mentioned earlier, in Bangkok, and also certification in General Breast Surgery and endoscopic breast surgery. That is something very, expertise need a special lab expert in here in Tokyo. She is also practicing general surgery and breast endocrine with the National Specialist Registered Surgeon, very active with this medical organization. Now, without further ado, very briefly, we would like to know more and tap more on your expertise. I would suggest that you could always make an appointment with Dr. Suraya, who is engaged with Gleneagles Hospital, Kuala Lumpur. I would like to invite our Pink Community President, Mahani Kasim, before we start, listening out to Dr. Suraya's sharing. Mahani, a few words.
Okay, good morning everyone. Assalamualaikum. Our distinguished speaker, Dr. Suraya, Datin, fellow members of Pink Unity, and partners. I can talk for hours about Dr. Suraya, then it would be my talk instead of Dr. Suraya, so I won't do that. But on behalf of Pink Unity and National Cancer Society Malaysia, we would like to thank Dr. Suraya for making time for us. We know you're so busy, it's so precious for us. And among the audience today are your patients, and I'm one of those. She's the one who told me while I'm buttoning up after her beautiful work on my breast that I got cancer. I remember that. She's not only a great surgeon, but she's also a great friend to all her patients. I didn't feel that I was talking to a doctor. She treated her patients as her friends. So for that, on behalf of all your patients, I would like to thank you. And on behalf of all of our Pink Unity members who are present here and also via the Facebook Live, we thank you from the bottom of our heart, and we know we will learn so much from you today. Thank you, Dr. Suraya.
Ladies and gentlemen, please welcome Dr. Suraya Baharudin.
Assalamualaikum warahmatullahi wabarakatuh. Very good morning to everyone here, and also those who joined us from FB Live. And I would like to thank Pink Unity especially for organizing this and inviting me, and also NCSM, collaboration to NCSM. NCSM has always been my supporters for all my events since I started treating breast cancer patients, and all the NGOs and breast cancer support team. I'm always their ardent supporters from beginning until now, because they have given me a lot of support to my patient, which I may not be able to give during the short time that I'm with them and while treating them. So thank you very much to all. Okay, so I'm going to share today two talks basically about breast cancer. You know, I've been doing this for many, many years, and I realized that I cannot stop. Because there will always new people, you know, that are being diagnosed, and from what I noticed, this awareness needs to be continued, because once we stop, then people are not aware of what's going on. Okay, so I will go back to basic, basically, about just an overview of breast cancer. Okay. So why are we always talking about breast cancer? You know, for many, many years. Because first and foremost, breast cancer is the #1 cancer for all females all over the world. I think everybody knows that, isn't it? It's the #1 killer, okay, for breast cancer, for women all over the world. So of course, when we see every year, statistically, the incidence has increased, okay, not only in Malaysia, but everywhere around the world. So that's what is worrying us, okay, as doctors for treating breast cancer. So what I worry also is that last time, way back when I started my journey as a surgeon, okay, Usually I don't really see younger women having breast cancer, you see, so they're all around 40 to 55, that's the most common age group. But now I'm getting like 24, 25, 27, okay, years old with breast cancer, so that's why it's worrying us, okay? And that's why I keep on continue giving all this talk, giving all these lectures, because I want them to come early, okay? Because of course, it's difficult for us. Of course, there are preventions, but there are some cases where, you know, despite having doing all the preventions, we still get it, right? So like in Malaysia, it's all 1 in 90. Last time it used to be 1 in 21. Now we're catching up with US. US is 1 in 8. And even the European countries, they are even worse than us. But mind you, we are actually catching up, you know. So that's why it is important about all this education regarding breast cancer, because early detection will definitely translate to better survival. Okay? Okay, this is the current situation in Malaysia. If you notice, for 10 years, we are still getting patients coming in at stage 3, okay, and stage 4. This is about 40% of cases are coming in not at early stage, okay. So, and 50% of women basically presented, you know, below the age of 50 nowadays, okay, and the incidence is highest among the Chinese, okay. The major ethnicity is Chinese is the highest, as compared to the Malay and the Indian. Partly because my hypothesis is basically the Chinese has more denser breasts. That's what I noticed. Their breasts are more dense. So if you read up about dense breasts, they have higher risk as compared to others who are less dense. Okay? And when we talk about survival, okay, survival, and what we notice, the Malay has the poorer survival. I will explain later. There's always a study going on, especially by UN, the NMS group. Okay, why is that the Malay has poorer survival? Okay, so if you look at the trend now, stage 1, stage 2, stage 3, it's not that clear 1 year and 5 years. So if you look stage 4, of course, it's lower. So when you are diagnosed with later stage, okay, of course your survival is lesser as compared to those which is in stage 1 disease. Okay. And of course, when you talk about cancer, breast cancer, male also have breast cancer. So far as 20 over years of experience, I have treated like 4 or 5 male breast cancer. It's not as common, they're only about 1% of population. Okay, why do cancer patients have poorer survival in Malaysia? So basically, there's a study that was done by our UMMC colleague. Okay, so based on their studies, they noted that why is that our women presented late? It's because their lack of awareness. Okay, poor awareness and knowledge. So they don't really know what are the risk factors, how to detect and all that. And of course, inequity of access to optimal treatment. Okay, of course, when you talk about inequity, if you talk about people in East Malaysia and West Malaysia, of course, there's disparity. Because in KL, every few hundred meters, you get is either government hospital or private hospital, right? But not in East Malaysia. I worked in Tawau for 2 years, and I know how things like when I was a medical officer. It's so difficult to get access. People have to take how many hours boat journey to come to Tawau. To have to go through all the states, I have traveled to all the interiors, it's not easy. Okay, so and even East and West East Malaysia, West Malaysia also is different. I was in Kota Baru, you listen to my where I go everywhere basically. I was in Kota Baru, in Terengganu, and now in KL, it's so much difference. When you talk about access to good medical treatment. Okay, so and also socioeconomic status and education level. Of course, this is so much true in all cancers. Because when you don't have that much of financial resources, of course, the limitation is there for better treatment. Okay, so and of course, fear and denial. This is something that is difficult. No matter how, that's why we need you all, the support team. So I always say my patient to be unity. And also last time when I was in Suraya, we had the Pink Rock group. So my patients are the one who help me to take care of my new patients to overcome their fear and denial. Because you are the ambassadors, you are the survivors. So when they look at you, you have gone through treatment and now you're back to your normal life, it is a motivational support for them, for the newcomers. So that's the solution I can't give. You see, I can't get. So that's the reason we need all of you. Okay. So, and then of course another one is non-compliance to optimal treatment. This is also important. So sometimes, you know, when we treat patient, we have already planned out what is, and every patient is different. Okay, you cannot say there are some patients telling me, well, doctor, I'm also stage 2, and she's stage 2, why is that? Mine is different than yours. Then I will talk about that later. We're getting personalized, okay, treatment and care. Okay, so it's, and once we already plan out, you have to fix to the schedule. You cannot delay your treatment. Once you delay your treatment, then the effectiveness will be there, you see. So these are the reasons about compliance to treatment. And when you are not compliant, the effect is that then the cancer will grow back faster, you know, recurrence. When you talk about what is the most thing that you fear as a breast cancer patient, or what cancer patient will say, is for the cancer to come back, right? That's the most fear that they have. So it's important for you to make sure that you're compliant to your treatment. Okay? And believes in alternative and traditional medicine. This is another thing that is difficult to tackle. Because in Malaysia, you know, there's no regulation about all these traditional, everybody can claim this can cure cancer, you know, without and going through trials. Like as doctors, our medicine has gone through phase 1, phase 2, phase 3 trial before we can use it for patients, you see. So it has gone through screening, you see. But you know, all this alternative medicine is a bit difficult. It is actually something that is difficult for early medicine. So, and another thing is, because a lot of things that patients are feared to go through surgery, so that's the reason why they opted for alternative or traditional medicine. Another thing is lack of autonomy in decision. What does it mean? Basically, we Asian women, we are very obedient, okay, towards our parents, towards our spouse, you know. So I think it's not much of a problem. But when I was in Terengganu, Kota Baru, this is a very serious matter. No, the patient wanted to go for treatment, but yet the husband said no. At the end of the day, when the patient is in their deathbed, the husband also is nowhere to be seen. Okay? So these are a very common thing. Another thing, when they got cancer, they are being divorced because they got cancer. So this is something, and even in Putrajaya, I've got cases where the young breast cancer, the mother refused. Okay, the daughter wants to go for treatment, and yet the mother wanted to go for some other things. And bring back when the patient was diagnosed stage 2 disease. So by the time they brought back, it was already stage 4 disease. So this is something very sad for me, you know. As a doctor, I can't do anything because I'm not the parents, you see. So these are the things, okay? So who are at risk? This is a very important thing. When people always ask me, doctor, am I at risk of getting cancer? Being a woman is already a risk. Okay, that's already number 1. Okay? Being a woman itself is already a risk. Okay? Because you have a breast. And of course, me also has breast. Okay, so of course the next thing is genetic factor. Mind you, okay, newly diagnosed breast cancer, 80% they are the first to be diagnosed in the family. 10-20% only are genetic. So this myth, and all this is myth or misunderstanding. There's a lot of women think, oh, I don't have cancer in the family. Why should I worry? You know, yes, you need to worry because you know genetics only 10% to 20%. 80% they are the first in the family. Okay, another thing is early menarche, late menopause. Why is that so? People will ask me. Because when you have early menarche and late menopause, your cycles are longer. You know, we women, we have, you know, hormonal cycle, right? Before period, the hormone will be high and then low. We have all this cycle throughout our life until we become menopause. So the longer you are exposed to all these hormonal changes, the longer it is. Because when you talk about hormones, hormones will always stimulate your breast. Okay, so the longer it is, of course, the risk is there. Okay, and of course, hormonal treatment doesn't matter. I always ask patients, did they take oral contraceptive? Are they taking hormones for whatever reason? As long as it is hormone, doesn't matter for whatever reason. Is it because of PCOS, ovarian issue, irregular period? You're not as a contraceptive or for fertility treatment, if you are exposing yourself too long, more than 5 years, definitely your risk will increase because you keep on taking hormones and it will stimulate your breast. And mind you, 80% of women has lump in their breast. Okay, it's not something uncommon. Everybody, you can get all of you, I mean, those out in the street who doesn't have problem, if you scan them, 80% will have lump, but they are very small. Okay, they are very small. But of course, we do not know, okay, who will later progress and change into cancer, not all. Okay, so these are the things. And then another thing, exposure to radiation. Maybe it's because you work close with a radiation, your occupational, or you had previous cancer before that you have to go through radiation, then that's also a risk, okay? So, and another thing is not having kids. So means you are nulliparous. So it doesn't matter how long you're married, but as long as you do not have kids, means you do not breastfeed, your breast does not evolve, evolution of your breast. So then another thing is first child at 32, above 32 years, it means late childbirth, the first child late childbirth is also a risk. Okay, if you notice, there's a lot of risks there, right? And being obese, of course, is one of them. Okay, why being obese? You have to understand. Not only your ovary secretes estrogen, your peripheral fat. If you're more fat, you've got more fat than others, right? If you're obese, means more. You have a lot of fat there, so it will change to estrogen. Okay, so that's the reason why obesity has high risk of breast cancer and other cancers if you look into it. All right. So lack of exercises. So these are all the things. Being in the city, fast life, or a career woman nowadays. It's difficult for us to actually maintain to actually have a regular exercise. So prevention. These are all prevention. Regular exercises, eating healthy diet, no alcohol. This is very important. For you to, and another thing is not breastfeeding. Having child but not breastfeeding is also a risk factor. So that's why we always encourage women to breastfeed as long as they can. Because when you breastfeed, it is a sort of a prevention. It's not 100%, but there are some prevention for breast cancer. So you have to understand that, all right? So let's go to the next one. Am I going too slow or you don't understand? Okay, so another one is how do you know I have breast cancer? These are very important. How many of you really do breast self-examination regularly? Put your hands up. Well, that's good. But before you were diagnosed, did you really do it? No. No. That's why I always ask. So, once you get it, and only you're aware. We want the woman from 20 and above start doing their breast self-examination. This is very important tools and it's cheap. You do not have to pay anything. A doctor is free. You can always examine. Where do you examine your breast? After your period, meaning 10 days from the first day, or today is the last day, the first few days after the last day, you examine. Why? Because during that time, your hormone is the lowest and your breasts are softer. I mean, being you woman, everybody knows, right? Before your period, you have a bit of sore, sensitive, a bit of pain, some women. Then after the period, it's more softer. Then you can detect easier. So this is very important. Breast self-examination, okay? And of course, in our CPG guidelines, we encourage women to come forward. We are opportunistic screening, not like in overseas. Overseas is a must for them to come, For us, it's opportunistic. Means we don't force. You want to come, you come and do. So we always encourage at the age of 40 when you do mammogram. 40, we always do mammogram and ultrasound. Okay, if there's anything, we do the ultrasound as a complementary tools. But if you are 20s, if you really want to screen, yes, you can start doing your screening, but only ultrasound once a year. And if there's anything, you have to come to see us as breast surgeon, and we will advise you accordingly how frequently you need to do, especially those in high-risk group. High-risk group meaning those with families of breast cancer or those who are on long-term hormones for whatever reason, so the risk factor that we mentioned earlier. All right, so how to examine your breast? I think you just go through your YouTube. You can, there's so many ways, lying down, sitting up, and in so many languages, you can go through that. Okay, so this is very important. Okay, sign and symptoms. Because why I keep on telling this? Because there's a lot of women who are not aware of the symptoms. Okay, how many of you presented with lump in the breast? A lot? Yes. Among all the symptoms, lung is the most common symptom, but not only lungs. That's the main point that I want to emphasize here. Okay? Of course, lung is the most, 60% of cases presented with lung in the breast. But there are other symptoms, right? Skin dimpling. You know what's a skin dimpling? Suddenly you nampak lekuk dekat your breast. Because not all breasts they grow like this. Sometimes people in, if it's the deeper one. So you will see some skin dimpling. Skin redness, which sometimes might be mistaken for rashes. Okay, but it doesn't actually resolve with all the sorts of creams. Okay, and purely orange. So go back and see your orange. So you see the skin of the orange. You see, it's not. You see that picture? Yeah, that's not normal skin. So this is already cancer that already infiltrate your lymphatics beneath your skin, in your dermis. So then it looks like a skin of an orange, you see. So not necessarily you have a lump. Okay, some skin thickness, like this, or change in the shape and size. So some women will notice. Of course, I always tell all my patients. So far, I mean, treating for many years, I don't see right and left breast the same size. Okay, we are not born with same size, mind you. Of course, some are very subtle, you can't really see, but some are obvious. So when I remove one breast, okay, and I always measure the weight. So far, I've never seen, you get 1 kilo here, 1 kilo here, never. Okay, so it's never the same. Okay, but this is over time, you will see some of them, they shrink, become smaller, or they become bigger. This is also one of the signs. Okay, another thing, this is not common, but of course it represents. When you do breast self-examination, people always miss this. They only just do that and they didn't squeeze their nipple. It's important to actually squeeze the nipple, because if not, you will not see this what we call bloody nipple discharge. This is another sign of cancer. Okay, usually this cancer happens behind your nipple areolar complex. That's why you don't really actually feel it. So it comes presentation is with bloody nipple discharge. Another thing is nipple retraction. Okay, there are some women who are born with inverted nipple. Okay, so not all nipples are out. Okay, but you just have to be aware. If you do it, if you see it regularly, you will know whether is it normal or there's any changes or not. Alright. Another thing is ulcer or rash at the nipple. Okay, some people they do have eczema, very sensitive skin, dry skin. They do have some rashes and all that, but it's important for you to actually seek medical advice, especially if it doesn't resolve. Okay, and this is another thing, underarm swelling or lump. This is also another thing. People always miss the armpit. They always do this. Okay, they don't check the armpit. This is very important because some of the cancers which I do encounter, what we call occult breast cancer. Occult breast cancer means they have cancer in their breast, but it's very small but aggressive. So mammogram, ultrasound cannot pick up this lesion because it's very small. But they are very aggressive, so they already go to their lymph node. So they will present with a swelling at the armpit. So it's very unfortunate. It's not that common, but people do come in this way. Okay. All right. So how do you go about? Of course, there's again, you have to go for screening. So if you have all these kind of symptoms, you have to come forward. So what we will do? Of course, we will do mammogram if you're more than 40. Okay. So this is the images and how we do the mammogram. People always refuse. Some of them are refused. I know I've gone through myself many times with the mammogram. It's not something you walk in the park. It's not really painful. I think giving birth is more painful. So it's not, for me, it's discomfort. Okay, and now the new machine that we have, especially those in HKL, they have the latest machine. Okay, so they're very not that long, and they're metal, they're plastic plate, they're more comfortable to go through, So, and these are the images that you will get. What we see is just opacities, whitish opacities, and this needs to be rechecked by ultrasound. So that's why we always do two. Because if you only do mammogram, mammogram is only about 60% sensitive to pick up lesion, okay? But when you do ultrasound, then you will increase your sensitivity to pick up lesion almost about 90%. So that's why nowadays, like in my center now in Gleneagles, we always do two. I will never allow them to do one. Okay, because there are cases where cancer only be detected by ultrasound, especially in early stage. Okay, so that's what we want to detect in early stage. Okay, this is the ultrasound. So this is just going through the gel, looking. This is the images that we will get. So this is this one is not. This one we can do often, no, because it's not involve radiation. So sometimes I do ask them to come earlier 3 months, but not the mammogram, because mammogram is involved radiation. So usually we only do once a year. The most we will do 6 months. If we see something, then we will call them back in 6 months. Okay, so this is very important. Okay, when we see any lump, okay, we need to go for what we call biopsy. This is meaning we are taking some sample. We take a needle in the picture, like what you see in the picture. We take a needle and we take some sample from the lump. So, and the tissue, the sample, will be sent to the pathologist, and they will look in under the microscope to see what kind of cell is there. This is important step. A lot of women, I think especially private, they will ask doctor, why can't you just remove the lump? Why do I have to go through this procedure? Because breast cancer surgery and normal benign lump surgery is different. Okay, so when you talk about a lump which is non-cancer, you just remove the lump. Okay, you do not have to remove the lymph node. You do not have to claw out a bigger area to make sure that it is clean. You know, so you don't leave any residual cancer behind. So as much as possible, we do not want the patient to go through surgery many times, okay? And that will also be delayed. Another thing is because nowadays, the cancer treatment is totally different, which I will tell you in personalized and precision care. It is no longer like, you know, oh, this cancer, that's it, okay? If I can operate, I operate. Then we think about what to do next. This is 20 years ago. Nowadays, we are more precise. We want to know what type of cancer do you have. Because every type of cancer has got different treatments. Okay, this is the reason. So now it's more precise and personalized care rather than, you know, one fits all, you know, right? Okay, so this is the subtypes of breast cancer. When I first started as a medical student, these are all not in our book also. So it's all like, okay, it's just a cancer from which part of the breast it arises. But now we go through molecular type of breast cancer. What subtypes that they're having? Either they're having hormone positive cancer, which is the most common if you look at the blue color one, HR positive means hormone positive cancer, which comprises about 70 to 75% of breast cancer. And of course, there's also the aggressive one, which is the HER2 cancer, and the green color is the most aggressive, which is a triple negative breast cancer. They are not as common. If you look, they're only 12%, you know, 5%. The most common are the hormone positive cancer. So it's important for you to know what type of cancer do you have, because it involves the treatment, prognosis, and overall survival are different. Okay, so if you look even in this graph, okay, as you go to the triple negative, they're more aggressive as compared to those who are hormone positive cancer. Okay. Okay, so when I say aggressive and non-aggressive, because why do we really need to know? Okay, does it really make any change? Yes, for us doctors, treatment prognosis is very important for the patient, because usually the most common thing patient will ask doctor, lama lagi patient nak hidup, mesti kena tanya Allah, betul kan? So, but based on studies, okay, these are all based on studies, what I'm saying. So if you look at the prognosis of any subtypes, okay, if you look at the luminal A, which is the hormone positive, the blue color one, of course they're the most highest. They're better survival. But if you look at the basal type, the green one, this is very aggressive. Even despite on treatment, the cancer can grow in big while doing the treatment. This is how aggressive it is. You I've got last time, before all this, we used to operate, okay, can operate, we operate. And then by the time we want to know the result, we want to go for the chemotherapy, it grows back again to other places. You see how aggressive it is. So if you look at the words, you see the green one, if you see, 2 years only. This is what, I lost a lot of my triple negative cancer. In 3 years. They come, recently she comes in stage 1, stage 2 disease. But within 3 years, they recur, despite having all the treatments, that are necessary. So this is the importance of knowing, which subtypes of cancer do you have, so that we can plan out, properly, what is the treatment for the patient, okay? So of course, this is also important, okay? When you diagnose cancer, ideally, in overseas, even in private setup, we always do CT scan first. We need to know the staging upfront before deciding the treatment. But in government setup, it's different because of the resources. There's so many patients. You can't be waiting for a CT scan for 3 months and only decide. Then the cancer will always spread already. So these are all limitations, okay? So why we want to know? Because if you are already spread, surgery is not the first treatment. Okay, this is important. We want to know, which one comes first. Okay, so the important thing is if we want to know whether it is spread or not. Some patients, when the result come out, let's say it's spread to the bone or spread to the lung, some of them they really don't believe. They say, "Are you sure, doctor, that's my result?" Because I feel well. Okay, so when you talk about metastasis, we call this metastasis, it's this cancer spread to other organs, stage 4 disease. So if it's very small, you do not have symptoms. Like if it's just 5 millimeter nodule, 1 centimeter nodule, most of them say, "I'm fine, I don't have chest pain, I don't have cough, I don't have shortness of breath." Or even it goes to the bone, you will say, "I don't know, it's okay." I've got 127 years old girl came in recently. She's in the NIO, so she's very well, she's been doing sports and everything, but she's only spread to the lung and to the bone. She has a very aggressive cancer. So these are the things important because, and her tumor is only less than 2 centimeters. Can you imagine? So it's only spread. So it's not the size of your tumor it matters, it's the type of tumor that you have. Okay, people always say, besar ni mesti dah spread. No. It doesn't work that way. Okay, so this is the staging. People always ask, "Doctor, tahap berapa?" Which sometimes I wonder, you didn't really know what it means. Okay, so this is why I'm telling you about the stage. Okay, so staging is not only used for breast cancer, for all cancers. Okay, so for breast, when you talk about stage 1, meaning it's only confined to the breast. It doesn't spread to other areas, and it's always less than 2 centimeters. Okay, so once the cancer spread to the lymph node, okay, then you're already stage 2. And of course, if it's only to the lymph node and to the skin and everything, then you're only stage 3. If it's only spread to other organs, then it's only stage 4. Okay? So stage 4, sometimes you can have 1 centimeter, like I said, like the case just now, 2 centimeter that is already spread. So not necessarily it's the size. Why do we stage? Another thing, if you look at down there, this is the survival rate. Okay, so if you're diagnosed at stage 1 disease, last time we used to say it's almost cure if you diagnose stage 1, but I don't really say that anymore. I do have stage 1 that recurs after 10 years, so not necessarily not say it's a cure, but it's actually good survival rate for many years. Okay, and if you see down the line as you go to stage 4, 16% in 5 years. We always say our survival rate in 5 years, 10 years, Okay, treatment-wise, there are so many treatments nowadays available. Of course, the most important thing to diagnose, like what I said just now, triple assessment, go to see a doctor, the doctor examine you, do all the mammogram, ultrasound, biopsy, okay, and then do the CT scan for the staging, and then only we decide what treatment that you need to go through. Okay, surgery is the primary treatment. Primary means, in other words, like it or not, we have to go through surgery, either before or after. okay, your treatment. So is it surgery, chemotherapy, radiotherapy, hormonal therapy, targeted therapy, immunotherapy? It's never ending basis. You know, there's a lot of drugs available nowadays. Okay, but it's all about cost. Okay, whether especially the new drugs are not available in government. Okay, so and then of course after that, once you have completed the treatment, then you need to continue follow up with us. Okay, at least 5 to 10 years. Okay, after you complete your treatment, it depends on center to center. Okay, so then of course you need to go through your mammography, mammogram, and ultrasound. Okay. Okay, so since I'm a surgeon, of course I will talk about surgery. Okay, so these two questions always the most common questions that are being asked. Okay, can I keep my breast? Okay, this is I think most common as compared to is it safe to keep my breast? A lot of women would rather keep their breast rather than worry that if I keep my breast I can see them outside. Okay, so what are the surgeries that we do? These two are very common. It's either you remove your breast, which is what we call a mastectomy, or we do a breast conservation surgery. What does it mean basically? You just remove the tumor, the lump, with a cuff of normal tissue surrounding it, means bigger, wider excision with the lymph node excision. So this is what we call breast conservation surgery. If you look at the picture, the most top part, okay, this is tumor is at 12 o'clock, but of course the scar is not 12 o'clock. It is around the nipple, you hardly see it, because that's what we do as oncoplastic breast surgery. So there's a difference. People don't understand actually. Oncoplastic is something new in Malaysia, okay, where we give you, of course, we remove the tumor, but as much as possible, we give you a very good cosmetic outcome. Okay, so last time, those days when you have a lump, then the surgeon will just cut at the lump. So for oncologists and radiotherapists, they will know, okay, that's the lump. So now for them, it's a headache because sometimes they need to call me, doctor, I don't see a scar. Where is the lump? Where is the lump? So we always put plate, metal plate, at the base of the lump, so that when they want to shine you for radiotherapy, so at least they know where is actually the radiation. Because my scar is not always, it's not at the lump. Okay? Alright, so how do we decide as doctors which patient will have to go through either breast conservation or mastectomy? Sometimes there's no option. We will say you need that, you need mastectomy. You can't go for BCS. So how do we decide? One is the size of the tumor in relative to the size of the breast. What does it mean? That's why people comes to me, I always say, pakai cup apa, and then people were shocked. Kenapa doktor nak tahu I pakai cup apa? Because this is important, because if you've got a 3 centimeter tumor in a cup A, meaning small breast lah, with a cup C, of course it makes a lot of difference. Because remember I told you, when you do breast cancer surgery, you need to remove a bigger excision. So if a 3 centimeter with a flat breast, what is left? Nothing is left. I might not get a good cosmetic outcome first, and it will compromise the margin, and so then in cup A, I would then say mastectomy. But when you talk about cup C or bigger, I say, well, you can still keep the breast, you rotate it somehow, So these are the things. Number of tumor in your breast. There are some unfortunate women, they are not unifocal, means the cancer is not only there. They've got multiple areas, satu atas, satu bawah cancer. So when you talk about what we call this multifocal, it is not safe to keep the breast because there might be other areas that we might miss from imaging. So if you talk about multifocal, it's better to take it out. Alright? So BCS is contraindicated in inflammatory. What is inflammatory? It's not common breast cancer. Remember I told you the presentation just now, how do they present? They present with redness of the skin. That's all now. Redness, enlargement, redness, macam lepas besar, breastfeeding, bengkak susu macam tu. So this is inflammatory breast cancer. Means all the skin are involved. So this one definitely not for breast conservation. So you really have to go for mastectomy. BCS is not for patients who are contraindicated to radiotherapy. For example, they have got maybe lung cancer before, they have undergone radiotherapy to the chest. So this time I cannot give, because you have to understand, radiotherapy is not that you can give seberapa banyak you suka. There's a limitation to the dose, lifetime dose. Okay, that's why it's important to know how much they give you before. So if let's say initially you had a BCS before, of course when you do breast conservation, you have to go through radiotherapy. This you need to understand. If you don't keep your breast, your early stage, actually you don't have to go for it. But if you keep your breast, you have to go through radiotherapy. Because if you don't do radiotherapy, definitely it will recur back, just a matter of time, to the breast. Okay, so if you do breast conservation, you need to go for radiotherapy. So, but if you can't go for radiotherapy for whatever reason, then you cannot keep your breast. So that's the equation, very simple. Okay, so there are cases like when I was in Tawau, there's no radiotherapy center. They can't go to KL to. Then I would tell them, you just have to remove your breast because it's not available. Okay, or because they had previous relation before. Maybe they were diagnosed before 10 years ago with early breast cancer. So they did some breast conservation. And this time around, okay, they developed 10 years down the line a breast cancer, same breast. For sure, they cannot keep their breast anymore, even though their breast is big and last time the tumor was small and this time also is small. You know, we can actually go away this week, but no, because you had radiotherapy previously. So you can't be giving again. Alright? So another thing is genetic factor. So if you are a BRCA mutation patient, okay, so you have tested the genetic and you're positive, definitely you cannot go for breast conservation because your risks are higher. Okay, when you have this mutation, 80 to 85%, you will develop breast cancer in your lifetime. So that's the reason why those who have family members with breast cancer, we will send them to BRCA testing, especially in HKL, they have a genetic center, we will send you there. For example, like Angelina Jolie, you know, once she was it was something everybody was talking about Angelina Jolie removing her breast. She's not breast cancer, mind you. Everybody was confused. They thought that she had breast cancer. No, she didn't have breast cancer. Her mother had breast cancer. Her sister had breast cancer. When you have got two family members, definitely they will do this test in overseas. Not here. Here we don't force you. So they do the genetic testing and they are positive. They have that mutation. So that's why when one has mutation, they will call the siblings. Okay, and the children to be tested. So she had that gene, mutated genes, but she did not have breast cancer. So then she opted for mastectomy as a prophylaxis because if she didn't remove her breast, she will have breast cancer, 80 to 85%. It's just a matter of time. It's like a time bomb. So it's just usually they give an option. Either you very close follow up or you just remove your breast. Right? Okay, so what is the impact of mastectomy on patients? We can understand, you know, based on some study last time also, when you talk about non-compliance to treatment, especially surgery, okay, in UM, they noted that why is that patient non-compliant? The patient didn't turn up for the surgery because patient refused mastectomy, okay? Some of them they refuse mastectomy, but nowadays we can give you a new breast at the same time. That's not an issue, okay? So why is that sometimes the problem is mastectomy? Okay, basically it's more of physical function. If your breasts are small, it's not much of a problem basically. But if your breasts are big, okay, when you remove one side, you will have a problem with your posture definitely because it's like datching, you know. When one is empty, you will be lopsided, definitely. Okay, lopsided, and once you are lopsided, your spine will also tilted, you have neck pain, neck spasm, all this will have problem. But only for those with big breasts. That's why we advise you to wear this external prosthesis if you do not want a reconstruction. Okay? And of course, psychological, you know, especially in young women, they cannot accept it, you know, or if you don't have a breast. So they lead to depression and more body image, social status, sexual function, you know, like I said, some husband may find that the women are less feminine and less attractive. Okay? So that's the reason why I went and embarked on doing oncoplastic and reconstructive surgery. Last time, 10 years ago, the breast surgeon are not doing reconstruction. Okay, we only send the plastic surgeon. About plastic surgeon, you know, they are very scarce. Even for us, breast surgeon now, I think it's about 30 plus in Malaysia. People like me. So there's not many last time. So waiting time is long. So that's the problem. So that's why now we have breast surgeon doing their own reconstruction. So how do we do reconstruction? Of course, there are two ways of doing it. Either you use implant, okay, or you use your own body tissue, which is either your tummy fat here, Really, and a muscle, it's very, a lot of women have it, So it's, so don't be too skinny, yeah? Don't be too skinny, so at least we can use this. I always say people who want all this, I would say, you go for one skin, and I say, I don't want this. I say, go eat first. Gain some fat first, and come back and do your reconstruction. Okay, because we need that fat, that body to create a new breast. Or we can use the one at the side here, which is what lattice muscles have. Some women, they are not fat here, but they're fat here, all the way there, Cool. All right, so that's very important for us to use. Okay, so this is implant reconstruction. When we talk about implant reconstruction, the problem in Malaysia is it's not covered by insurance. And you have to buy yourself. Okay, one implant costs about 3,000 to 4,000 for one implant. Okay, so implant is more simpler way of doing, and even in overseas European countries, this is the first reconstruction they will go for. All this muscle and all this, they're all second option. Okay, so implant, the problem is with the implant is your body will age, but not your implant. So your breast will always look younger, but your body will go down some. Okay. Okay, so this is a more detailed how we do it. So just taking and then just bring it up and create a mold. Okay, and it's not technically it's not easy, but it's doable. And usually nowadays, I prefer, for me personally, I prefer to do immediate reconstruction. Meaning, we remove your breast and then we reconstruct your breast at the same timing. Okay, then by the time you wake up, you say, I still have my breast. But of course, it's not the original one. Of course, God created one is much more better than the one I create. Okay? Okay, managing expectations. So sometimes when I talk about doing reconstruction, like what I said just now, God creation is much better than what we human create. Okay, so it's not easy to have exactly similar shape and size. So because when you talk about implants, they come in different sizes, but their gap is more. I have like 200, the next one is 250. It's quite far the gap, so it's difficult for us. Like you see in the picture, you couldn't find a matching. So if it's too big, somebody would have a really big one. It's difficult really to match. So new breast created will not be the same. This is very important. And some, I've got patients who I've done reconstruction, young patient, they will say, doctor, because I guess it looks so real. They say, doctor, I can breastfeed my child. Difficult to answer, yeah? So how lah? There's no breast, there's skin there, nipple, and then not every procedure is suitable for every patient. So you cannot actually pick and choose. I will discuss with you what is the best for you. Okay, for example, if you are diabetic, you are on steroids, I would definitely say no to implant. Or you have some vascular disease, then I don't do autologous using your back because your vessels are all diseased. So once I pull here, this might die. Okay, so there are a lot of factors to take into account. So, and when you talk about breast reconstruction, it is not without any possible complication. Okay, so these are the things. That's why sometimes people they susah lah nak pergi doktor, saya tak tahu lah. They say, if you really want to keep it simple, just have a mastectomy and use an external procedures. So these are the things, Alright, external procedures. This is what we always advise with those who doesn't want reconstruction. Another about reconstruction, we can do immediate and also we can do delay. Let's say you have done your mastectomy, you have got patients who the doctor will come and bring back, doctor, I want to spend money for my mom to give a new breast. So after like, a couple years, no doubt we can do it, but of course, like I said, it's not without any problem, that can arise. So these are all the external processes. Usually I always engage myself with Ken, Amanita or Yasan Penyayang Malaysia. They can give you a better advice on which type of external breast prosthesis to use. Alright, so what are the treatments? So just briefly, like I said, this is just an overview. Chemotherapy. A lot of people don't understand what's actually chemotherapy. This is basically intravenous drug, that was given. Basically depends on patient to patient. Usually it's 6 cycles. Every 3 weeks you get one chemotherapy, will last about 1 hour or most or 2 hours, and you go back. Okay. So and every 3 weeks you get it until 6 cycles, then it's done. Okay. There are some people who are longer, some people who are shorter. Okay. And of course, when you talk about chemotherapy, I always say people are always afraid of chemotherapy. They always say, mati lah doktor, chemotherapy menyebabkan patient mati. It's actually not the case. No, if you're well, if you're not well, we definitely not give you chemotherapy. We'll send you to straight away palliative care. If you come in already late stage, stage 4 disease, liver involved or whatnot, we actually sometimes don't in fact give you treatment. Because we know that if we give you chemotherapy, your body cannot take it. And of course you will die. It's not because you will die, because you're already in advanced disease. Okay? So, but if you take the chemotherapy, of course I'm not saying that this is something, easy, it's difficult. I think you are more aware than me. You have to go through it. Of course, first cycle, you'll be tired, lethargic, nausea, vomiting, your hair, your hair will fall up to the second or the third cycle. But I always tell my patient, nothing is easy in life. Okay, you want to fight cancer, this is a battle. If you go to the battle, you see our army all goes to battle. You know how it's difficult it is. So it's you are actually going to a battle. It's not easy. You have to go through it, but you have to make sure that you keep yourself positive, keep yourself healthy. It's only 6 cycles. It's not lifelong. Okay, to kill the cell, cancer cell, is not easy. Okay, all right. So this is something that you need to consider. Chemotherapy. Usually we don't give this in stage 1 disease. It's only in stage 2 and above. So that's why I always say, please come early. So if you are stage 1, surgery only and radiotherapy and make ubat makan. That's it. No chemotherapy. Okay? Doesn't matter what subtype. Even though you're triple negative, you're HER2 cancer, if you come to me less than 1 centimeter, no chemotherapy. Yeah? Radiotherapy, like what I said just now, you're just lying down on this machine and they give you some radiation about 10 minutes, right? So 10 minutes, okay? And it depends. Some people, depends on type of cancer, usually 3 weeks, right? Finish, that's it. And usually it is a must for those who go for breast conservation or mastectomy if they are stage 3 and 4, it's compulsory also. Okay, and usually it will be given after surgery or chemotherapy, okay? Alright, so this is hormonal therapy. This is only for hormone positive cancer. Remember, I told you hormone positive cancers are the most common cancers, and this is one of the treatment, which is hormonal therapy, either tamoxifen or Femara. Okay, especially those who are still not menopause, you have to be on tamoxifen. Those who are already menopause, then we will give you Femara. Or those who are young with aggressive cancer or possibly spread, we will definitely make them menopause with so many other ways and give them Femara. Okay, and this is always 5 to 10 years, okay, depending on case to case visit. Okay, this is another new one called immunotherapy. This is another new drug, which is also a targeted therapy. Remember I told you about triple negative breast cancer, they are the worst cancer, they are very aggressive. Their treatment are limited, okay? Limited, not like the hormone positive cancer. So nowadays we've got new treatment coming up, immunotherapy. What does these drugs do? They use your immune system to attack the cancer cell. So this is how they work, okay? So it is used in triple negative breast cancer only, okay? At the moment, okay? So this is already, I'm going to my second after this, just give me a break just for a while after this. So take home message, breast cancer is treatable, okay? And it's not a death sentence, okay? If you catch in the early stage, even stage 2 or even stage 3, with treatment, you can even last more than 5 to 10 years. Okay, and I always tell my patient, they always think, when you have cancer, you always think of that, whatever cancer. And I always tell my patient, and myself, for that matter, when you talk about death, it's already there. It's a matter of time. Everybody will die. So why you want to think about that when it's not beyond your control? So whatever it is, what you have, just go through it, breeze through it. What you have to go through treatment or what, just live your life as it is. The time will come. Not necessarily you will die of cancer. There's so many of my patients who actually survived but died of accident. You see, so it's time for her and she died of accident. So don't think about that. When you think about that, you will be depressed and you will be down, and it's not good. You have to have a positive mind, positive thinking, no negativity. Then you can always breeze through your treatment. Okay, so compliance to treatment. This is also important. If you are not compliant, you don't have better survival. Okay, and your chances of recurrence are higher. So, and another thing is breast reconstruction is an option and should be available in all center and to all women. For us, because we are very limited, we can only I mean, our services are only in big hospital. Like even Suraya also last time they don't have, and I was given a task with Ms. Juliana to open a center, a unit there, to give the service to Suraya. Like in KL last time was HKL was the most established, and then after that Putrajaya, then I'm in Suraya. So there's only 3 centers here in government hospital. Of course, in breast, in private, there's always a lot. Okay. All right. Shall we go through the next one? Any questions just while you're fixing things?
Yeah, there's now you mentioned about the immunotherapy
Immunotherapy,
for
yes.
the
Triple
triple
negative,
negative. So it can only be given when you are removing the breast or like years
Okay.
after that.
All right. That will uncover in the second topic. Because it is something new. So, okay. My second, because I really need to shorten my thought because I have to bring my dad for appointment. Okay. So, my second talk is about personalized and precision medicine. Okay, updates on breast cancer treatment. So, last time when we started, okay, it's like when you diagnose with breast cancer, everybody will go through the same pathways, if it's operable, you operate. If it's not operable, you give chemo. Chemo fits all, So there's no such things anymore. So this is what we call personalized and precision medicine. This is what I said just now. Stage 2, if you're different cancer, is different. So every patient will get different treatment based on their tumor. Okay. So what that means to say, if you look at the picture now, look at the one below. So you have breast cancer, then they will look at your tumor. How do they behave, their mutation and everything. Then only we will decide for your treatment. So it is a tailored kind of treatment to every patient. Okay? Alright, so what are the evolution, okay, of this? How do we evolve from previously until now? How do we get here? Where we can get a personalized or precise treatment for every patient. So if you look at last time when we do core biopsy, remember I told you about the biopsy? Last time we used to get just invasive cancer, that's it, it's enough. But now, on a core biopsy, with the latest technology, we can know the subtype already from just the core biopsy. Last time we need to operate first, get a bigger chunk, then only they know. But now with that small sample, we can only know already what type of cancer do we have, how aggressive it is, grade 1, grade 2, grade 3, and there's so many markers actually we can do on that small biopsy to know what type of cancer, so that we can decide precisely what to give you. All right? So it's all about diagnosis of cancer treatment. Another one is specific tests. Now we have got a test which we can know whether we want to know whether are you sensitive or not to chemotherapy, or especially in hormone positive cancer. We can, in a hormone positive cancer, we can do this test, which is widely used in overseas, which is not widely used here because it's very expensive. So in hormone positive cancer, we can take the tumor and go through this test, what we call oncotype check, and we want to know whether are you sensitive or not to chemotherapy or hormonal therapy. So even though you're stage 2 or stage 3, if you're not sensitive, we will not give you chemotherapy. You understand or not? So rather than blindly give cuba dulu tengok dia respond tak, we can actually use this test and know. So if you're not sensitive, why waste the money? Six cycle of thousands of ringgit to give you chemotherapy, it doesn't work. And you will suffer with all the side effects, right? So another one is specific treatment to different type of cancer and stage of disease. Okay, we'll go through one by one, basically. And the most important thing nowadays is the role of new adjuvant. Remember last time when I started, it's like, when we see a patient, we say, kecil besar, okay, boleh operate dulu. Okay? Then only kita decide. Okay? Now it's no longer that way. Now a lot of cases in Germany, in European countries, 80% of their breast cancer will go through neoadjuvant treatment first, then only surgery. I will tell you what is neoadjuvant treatment. I know you don't understand what I mean neoadjuvant, right? I will explain it. Okay, so this is what I'm telling you just now. We first started in 1970s and 20s. What we'll get is just, okay, it's invasive cancer. But as long as we go, as years goes by, we will see the genomic testing. This is what I'm telling you, whether you are HER2, triple negative, on just the core biopsy. So that's how things evolve along the way. Okay? Alright, so there are other markers. Remember, I do not only knowing your subtypes of breast cancer, there are also what we call kind 67. This is markers that we look into to know whether are you having an aggressive cancer that can actually spread faster, or are you responding on chemotherapy? So these are all the markers. Another thing is what we call liquid biopsy. I think here not many centers are doing this. Is really something new. So what you can do, basically, you can take, let's say, you're already metastasis, meaning you recur, your cancer recur. Okay? So we can take that cancer that recurs and do this testing and see whether are you still this tumor, is it still sensitive or not to this treatment or not? Are they, look, what we see is we predict resistance. Are you already resistant or not? And we see the response. So this is all what we call personalized treatment. You know, not everybody the same. Even in recur, not all will be resistant. So we can still actually use a similar types of treatment, but a different group or something like that. Okay. Okay. This is a test that I'm telling you just now, what we call oncotype DX. So in this test, this is especially for hormone-positive cancer. So those who are newly diagnosed, especially those yang, especially tak nak chemo lah, especially the more that they will do this test because they want to know. Then no, that was the point of me going to chemo if I'm not sensitive. So we can do this test. So they are actually scoring. So what I'm sharing is this is scoring that will come out like this. So if you are older than 50, if your score is less than 25, then you got no benefit from chemotherapy. So they will give you what we call CDK4 or 6, the different type of groups of which is oral treatment, but oral chemotherapy of different type. So, and if you're younger, of course, there are more scoring system. So if you higher score, then only you will benefit from chemotherapy. So this is something very important, I think, which we need to use in Malaysia, so that we will cut down the cost of chemotherapy rather than give everybody stage 2 and above chemotherapy, which they might not respond. So they might also go to a different type of groups that will be better. Okay? Okay, this is what I call specific treatment of different types. Remember, I told you we need to know what subtypes do we have. Because if you're hormone-positive cancer, you of course, we give you endocrine therapy. Okay, and we have got, when we talk about endocrine therapy, there's always tamoxifen, there's always aromatase inhibitor. There are so many different types of subgroup, which is your Humira, and we can give you Zoladex to make you menopause, if you're not menopause. And we have, this is the latest one, what we call, it is a targeted, but this is a biological therapy. Okay, it is oral. This is good. Last time when we brought to Malaysia, we used for those who are hormone positive that already spread to other organs. Now, there's no indication that we can use upfront, even in early stage, so that you can prevent the cancer from coming back early. So there's a lot of things that are going on in the breast cancer. HER2 cancer. So when you talk HER2 cancer, they don't respond to endocrine therapy. That's the reason why we need to know what type of cancer upfront. So we can't be giving everybody the same. Okay? So when we talk about HER2 cancer, HER2 and triple negative, they are all aggressive cancer. If your tumor, even it is early nowadays, 2 centimeter and above, 2 centimeter, 3 centimeter doesn't spread that side, you have to go through for neoadjuvant treatment. Means we give you chemotherapy with targeted therapy first, then we do the surgery, and then you continue with targeted therapy. This kind of patient who has undergone this kind of treatment compared to those before, they do better. They have less chances of recurrence, they have better survival. These are all proven by studies all over the world. Okay? So when you talk about their drugs, you need what we call Herceptin and Perjeta. These two drugs, these are miracle drugs, seriously. Last time we only have Herceptin, now we have Perjeta. So those who have money, we always give 2 blockade. And by the time I operate, the result, most of my patients will be negative. There's no more cancer cells. Yes, that's how miracle the drug is for HER2 cancer. So these are the things. There's so many drugs available, but it's all about money. It's all about money, okay? They are all good drugs. So when we talk about triple negative, like I said, when I say triple negative, I will say that chances of recurrence is very high. Usually they will recur within like 3 years or so, either to the same breast, to the opposite breast, or to other organs. So nowadays we have got what we call immunotherapy. Okay, immunotherapy is a new thing, Keytruda. So usually we always give last time to those who metastatic also. Okay, so the spread will keep by gila. This is a second line. And also that also we will check the tissue whether they are sensitive or not to this drug. So this is all personalized care. Remember I told you? So if you're not sensitive to this drug, you cannot take this drug. So then you've got no more option. Then, you know, we can't offer you anything else, you know, this triple negative. But now the new what we call trials has shown that if we give in early stage breast cancer triple negative upfront before surgery, they do better. So I'm seeing nowadays, I think this trial is just 1 year here in Malaysia. And I always go all out for, remember I told you about 27 years old girl with triple negative, comes before, by the time we do everything, it becomes like 6, 8, 7 millimeter. So we give this Keytruda. So by the time I saw her, it's already not palpable. 5 cycle already. Hilang. Kadang tak rasa, but scan maybe few millimeters. So that's how good it is. Okay? So these are the things that we talk about: personalized and precise precision medicine. Okay, so I will talk about what is neoadjuvant. This is all terminologies that we commonly use. Okay, when we talk about neoadjuvant, what does it mean? It's basically we give you treatment given before the primary course of treatment. It means before surgery, pre-surgery. So that's what it means. We say, okay, kita kasih you neoadjuvant. Neoadjuvant itu maksudnya chemotherapy, targeted therapy before your surgery. So if we give you after your surgery, then it will become an adjuvant treatment. Okay, so it is given after your surgery, which is post-operative. So that's what it means. Another thing that I want you to know is what we call pathological complete response. So in this era, with all this personalized precision care, what we want is this. What I mean, an absence of or residual of the cancer on HPE after you have completed your treatment. So, and following completion of your neoadjuvant systemic treatment. This is what we want. So if we give you targeted treatment of chemotherapy and then we do surgery and then we send to the lab, it's nowhere to be sent. So meaning you're a good responder, you have achieved PCR. So why is important PCR? Okay, why is it important? Because, you read the one below lah, main goal of neoadjuvant chemotherapy is to achieve PCR. Okay, why? But PCR associated with better overall survival. So longer survival, lower recurrence. This is what we always talk about when we talk about cancer treatment. Okay, so why are we giving neoadjuvant? Who are those who receive neoadjuvant treatments? Means, like I said, they are triple negative cancer, they are HER2 cancers, inflammatory cancer, they are all aggressive cancers, or hormone positive but late stage, stage 3, okay, disease or stage 4 disease. Okay, so the advantages is last time, you know, like especially those who comes with big tumor and they refuse to do mastectomy. So when we give this neoadjuvant treatment, it is to shrink the tumor so that we can go for breast conservation surgery. Okay, so and of course to downstage your disease, in other words, also at a lymph node. Okay. So another thing is to evaluate whether you're sensitive or not to all this treatment. If you respond well, then it's if you not respond, then you'll be changed to a different drugs. Okay. So and of course we take after that after the surgery what to give you. So the disadvantages of neoadjuvant, of course, as for us, when you go through neoadjuvant surgery, you want to go for reconstruction, for example, your risks are higher for infection because you're healing. Okay, it's more of healing after the surgery because when we bang you with a lot of all these drugs, your immunity might be low. So then your healing will be impaired. So you might have problem after surgery, infection, this kind of thing. So that is why I always tell those I have treated before, my definitely counseling is always please eat well, drink ensure gold, make sure you take enough protein, because I don't want when I do the surgery suddenly, you have all this infection, then you will delay your treatment. If your wound does not heal, you cannot move on with therapy after that. There will be delay. Remember I told you about compliance of treatment and the timing? That's the reason why. Okay? Okay, this is basically a simple algorithm of how do we decide? Okay, simple one. Okay, I think all the doctors need to know this. Okay? You don't know what other studies are going on. So basically, when you see breast cancer, if they are very small, less than 2 centimeter, doesn't matter, means they are early stage. Now we're talking about a very small 1.5 and below, 1 centimeter, detected by screening, you know. So even though they're triple negative or they're HER2 cancer, they go for surgery straight. They don't need all these high-fi drugs, no? No need, just surgery. You know, small tumors, 1.5 and less, okay? Or if they are bigger tumors, more than 1.5, some people put as 1.5, some people put as 2, okay? Then, if they are triple negative, if they are HER2, mesti pergi neoadjuvant chemotherapy. Mesti, walaupun lymph node are not involved. So this is the current treatment. Or if they are hormone positive but lymph node dah terlibat, then you still have to go for neoadjuvant chemotherapy. Okay, then after that only we decide whether you go for clinical, you want to go for breast conservation. That's why I need to see you before in the mid of your treatment and also just after your treatment because I need to decide, okay, regarding the surgery, which one suits you. Okay, this is what when we talk about neoadjuvant, you know, there are some doctors who are not breast surgeons always say to me, Suraya, why do you like to send patients for neoadjuvant chemo? Why do you like chemo so much? I guess those who doesn't seem to know, because this is something new. So when you talk about breast cancer, there are a few guidelines. We have our patient CPG guideline. You can go to the MOH, you can actually Google and go through it for the breast cancer treatment innovation practice guideline. Okay, and these are all St. Gallen, ESMO guideline. They are all European and American guidelines that we also follow. Okay, they are all latest guidelines. So if you look at ESMO guidelines, so if you read there, is pre-surgery treatment, means neoadjuvant treatment, allows assessment of therapy response, like what I said, okay, which is of well-established prognostic value, and may guide choice of post-operative treatment, and this in subtype highly sensitive to chemotherapy, such as triple negative and HER2 cancer, neoadjuvant approach should be preferred. Okay, this is European. Alright? So St. Gallen, this is 2019, this is American. So if you say 98% agree on indication of neoadjuvant treatment for stage 2 and stage 3 triple negative cancer and HER2 cancer, which was in line with their previous guidelines. In other words, they did 2017 pun in America. Okay, so but it's just that when they renew the new guidelines, it is still the same. It never changed. When you talk about medicine, things always evolve. Things that might be good this time might not be good later. So it's always evolve. So this is the latest one. Okay, then we talk about Malaysian. Malaysian mesti nak cakap kan cerita semak salih kan. Kita pun ada guideline. Okay, so guideline kita ada. Okay, triple negative HER2 positive tumor have increased frequency. Maksudnya very good response. PCR. Remember what's the meaning of PCR just now? Everybody knows kan? Following to neoadjuvant chemotherapy in breast cancer. So nowadays it's not only for yang dah merembak-rembak nanti, it's only also given for early triple negative HER2 cancer. Okay, so that's why recommendation it needs to be offered. Okay, in all breast cancer lah, especially to enable breast conservation surgery. Of course, when we talk about all these drugs, they have side effects also. So jangan ingat makan Panadol pun boleh side effect. Okay, Panadol, paracetamol, whatever lah. Simple drugs pun you can have side effect. And this kind of drugs. That's why when we give, you need to be monitored by the oncology. Jangan lagi disappointment. Nanti ada problem, dah susah. Okay, so of course they do have side effect, but it can be overcome. Okay, alright. Okay, so I'm already in my summary. I think I finished early. It's okay, right? So summary is personalized and precision medicine is new and evolving to give the best care treatment for cancer patients. Okay, so and then it will translate to more precise and targeted treatment that leads to better prognosis and lower recurrence and overall survival. These are the 3 things that we look into when we treat cancer patients. Okay, I think I'm done. Right. Website. Any questions?